Hi, my name is Tyler Owens. I'm a student physical therapist assistant at Jeff State, and this is my presentation for PTA 232. Let's get started. This presentation is based on a patient who is a 40-year-old male who has an L5-S1 disc herniation. His date of injury was 1 week ago. His mechanism of injury was lifting a 50-pound bag of concrete at work, and he has past medical histories of bilateral knee medial meniscectomies 5 and 10 years ago. So let's go back over just a little bit of anatomy. So intervertebral discs are the cushions between each vertebral body. They act as shock absorbers for external forces placed on the body, such as compression forces. Each intervertebral disc has two components. There's a strong outer layer called the annulus, and there's a soft jelly-like center called the nucleus pulposus. Disc herniations can happen a couple different ways. So they can be caused by single traumas, such as falling from a height. The compression forces that happen can cause this, or car crash. But the most common way is repetitive trauma and stress. So men and women that work in manual labor, that do a lot of standing and bending and twisting, are more susceptible to this type of injury. As you can see in this graphic here, you can see the compression forces happening and pushing that disc material posterior into the surrounding nerves. So what are our treatment goals? One of our treatment goals can be to centralize peripheral symptoms. So with nerve root compression, you're going to get radiculopathy often. And what that means is you're going to get numbness, tingling, pain going down posteriorly down into your leg. So we want to try to reduce that to try to shrink our painful area. It's much easier to treat a small area than a large area. Next, we want to try to reduce stress being placed on involved structures. So those nerve roots that are being compressed, we want to try to decompress those themselves. This will give the tissues time to heal and also relax. Third, we want to try to restore normal ADL function. So one of these patients' goals is to try to return to work, and we want to help try to get that patient back to work safely. PT interventions with this patient will include patient education activities, mechanical traction, soft tissue mobilization, and therapeutic exercise. Patient education activities will be used to address this patient's kyphotic, thoracic posture, and lateral shift to the left that's happening. Proper body mechanics will be taught to help reduce risk of re-injury upon his return to work. Mechanical traction will be used to separate vertebral bodies, which allows for decompression of surrounding nerve roots. It can also elongate and stretch paraspinal musculature. This patient would benefit from traction in prone because of the lumbosacral curvature of the spine and the direction of the herniated disc. Soft tissue mobilization can be used to stretch paraspinal musculature and can also aid in reducing muscle spasms and increase flexibility and mobility in the area. With therapeutic exercise, this patient may not be able to tolerate flexion-based activities. Exercises will be extension-based to encourage strengthening and lessen the likelihood that the herniation is made worse by physical therapy. There are some assessments that we need to be making every time this patient comes in. Some are subjective, some are objective. Some subjective assessments we need to make are pain scale and positions that increase or decrease symptoms. With pain scale, it will determine what PT is based on today. Is it more symptom management versus is it more exercise? Do we need to back down the exercises because of pain, or can we progress in difficulty and resistance? With positions, do we need to stay away from certain positions because they cause more pain, or are we able to challenge with new positions and activities? With objective, as far as posture goes, is there a lateral shift present? What does their kyphotic posture look like? Is it increased, decreased, lordotic? What does it look like today? And with gait, do they have an antalgic gait? What is their swing phase, their strike? What does that look like? Do their symptoms get better with walking? All these are things that we can look at and determine what our treatment looks like for the day. Soft tissue mobilization may be beneficial to this patient because it can be used to decrease muscle spasms. It can stretch and lengthen the fibers in the fascia. It can also be used to increase the flexibility and mobility in the area, and also use the gait theory to try to decrease pain in the area. The soft tissue mobilization technique I'm demonstrating here is longitudinal. So the longitudinal technique is more of a personal preference for me. I feel like it gives me the best control of pressure. but you can also use your fingers, your thumbs, or your forearm to apply pressure to the area. Just try to be mindful when using your fingers or your thumbs as to not poke or dig into the skin. You don't want to cause damage to the tissues. You're just trying to apply a stretch to the muscle and the fascia in the area. An educational activity that you can do with this patient is practicing squatting using legs and maintaining a neutral posture. Better body mechanics will help prevent further re-injury of this patient when they return back to work. This patient places more strain on their spine due to the previous knee surgeries. So proper body mechanics will help prevent further re-injury and reduce stress placed on the spine. This patient wants to lift 50 pounds at work. They are on a 20-pound lifting restriction with an ultimate goal of 50 and then beyond. So we want to help that patient achieve that goal, but achieve that goal safely. A home exercise for this patient is prone press-ups. So prone press-ups can be used to improve trunk range of motion and reduce pressure on nerves. I'm showing here a 10-second hold and relax with a way to progress this activity into more extension. Instructions to the patient can be to push up using your arms and stop at the point of discomfort. Hold this position for 10 seconds and repeat 10 times. Take breaks as you need them. Stop if there's any pain. You can use shorter times if you like, but you want to make sure that it's a nice controlled movement. You don't want any rapid or jerky motions. This exercise may be uncomfortable to the patient, but the position can be worked up to using a progression. Depending on how much extension the patient can tolerate, the progression can be as simple as just lying in prone, to lying in prone with pillows supporting their chest, and then to the two exercises shown here. Referencing a few slides back, the reason we want to do extension-based exercises with this patient is because we want to reduce the stress placed on the involved structures. Putting the lumbar spine into extension removes pressure from the anterior portion of the disc, and removing the stress from the area can allow for more healing to take place. The prognosis for this patient is good. He has good rehab potential. PT will be focusing on patient education, core and lower extremity strengthening, as well as symptom management. The return to previous level of function is likely as well. Addressing lower extremity flexibility and strength may allow this patient to use safer body mechanics when they turn back to work. Some activity modifications needed for lifting at work will be those same body modifications. This patient places more strain on his spine due to his past medical histories. So proper body mechanics is going to be essential in limiting further re-injury down the road. Disc herniations can take up to 6 to 12 weeks to heal. This means that tissues are still healing even after the patient is done with physical therapy. This patient has returned back to work with lifting restrictions. Using proper body mechanics and obeying these restrictions will help this patient return back to his previous level of functioning. 4 to 6 more weeks of physical therapy may be needed to get this patient back to where they want to be. So what's next in rehab? Let's move away from the static exercises that we started with and into more dynamic exercises that closer mimic what he's going to see at work. And then discharge the home exercise program. Discharge doesn't mean that they are done improving. They can and they should continue to improve with home exercise compliance and the education received while in therapy. We want to try to manage symptoms and address any correctable structural or mechanical issues possible. We also want to set as good a foundation for the patient to continue improving after they leave physical therapy. This concludes my presentation for PTA 232. Thanks for watching.